So this is a little team approach to unlocking data, and our team are very excited about being here. We, like Lara Croft, over the last 12 months in New South Wales Health, the districts, our colleagues in the pillars have been on a quest to unlock the data that we have. We know that technology, and in particular information technology, is changing rapidly, and much of our technology, our equipment, has data in it. Good quality, accessible data is needed to drive change, and we have more data than we have ever had, yet accessing it in a way that can drive change has been really problematic. And we know that major improvements in our health system, as we've seen over many years, occurs when managers and clinicians work together. Our system has actually been sustainable because we've been prepared to change and we've been prepared to work together. Our data mining and analytics is about more than just one district, one service. It is about all of us working together to be able to unlock this detail. So you didn't hear that, that was a twinkle. And the holy grail is access to timely, accurate data. Our data systems are complex and often not linked. They're time-consuming. It often takes months to get the data that we need. Many of our data systems are standalone and inaccessible. We've got great EMRs, but they're about a patient and a patient journey. They're not about how do we pull out that data to look at how we review services and outcomes. And as many clinicians say, it is tortuous. So the limitations of our current system are well known. They're labour intensive. Charlie before had to send out hundreds of reports to all of our departments so that we could have a discussion around clinical variation. Our coding audits were torturous in terms of getting that information to the 70 departments within RPA and Concord and Canterbury and our community teams. And access to real-time data has been problematic. Take it 6 months, 12 months, and then the time has passed for being able to make real change in those areas. So real-time access to data has been a challenge. So our data has been time-consuming, inefficient, and it has disengaged our clinicians. Often it's seen as just way too hard. So we've been on a bit of a journey, and we know that we can't manage what we can't analyse and monitor. We're data rich, but information poor, and it's hard to fix what you can't see. So we've been using STARS and the same data system that the ministry's been using to create an easy path to identify usable data so that we can do this in a much more efficient manner. So we've taken a whole range of data sources and pulled them all together into STARS, and we call it STARS because I couldn't remember anything else. My team had to find something easy for me. So what does STARS deliver to our clinicians and managers? It is simply a tool to increase our collective knowledge about our services, to be able to identify clinical variation and reduce unwarranted variation, to be able to use data to drive our models of care and improve clinical outcomes, to link all of our databases and to assist us in making cost savings, and very importantly, to support research to improve our clinical practice. So what does it offer? This is Indiana Jones with STARS breathing life into the EMR. So STARS offers us access, real-time access to a huge amount of data, not 3 months old, it's a week old, and in some of our apps it's actually refreshed every 3 hours. It unlocks the EMR and it's user-driven and flexible. So clinicians can interact with the data however they see fit. They don't have to do a little request for a report that goes off to an unknown body who might or might not respond. And the clinicians can determine the interfaces and determine the metrics that define the performance of their services and enables us to link databases. So STARS implementation, though, requires strong governance. It has to have clinicians and managers. It's no point managers driving it. This is about clinicians and managers working together. And they has to be properly resourced. So we have a team in our performance unit who helps to drive this. And it involves focus groups of managers and clinicians at all levels, junior and senior, all coming together to look how they can manage the data. So we have a STARS executive team, which is made up of managers, but very importantly, our clinicians, medical, nursing, allied health, junior and senior from all of our clinical areas. So the take-home messages for STARS is that this is a new and innovative data management system, but it is a tool, not a panacea. It needs clinicians and managers to work together to gain the maximum benefits, and it really is only as good as the data that is in it. And to manage this and to implement it well, we need adequate resources, educated and engaged clinicians and managers, and very importantly, strong clinical governance structures in place. So these are all our apps, and we're going to show you just one of them from our district, but from the ABF task force, we're also going to show you the ABM. We have a number of processes. One that's about being a district-led, where we work with clinicians and managers and key stakeholders to oversee our whole system within the district, where we have strong communication around particular DRGs. So we pick 5 DRGs a month, we look at that as a group, we then engage with our clinicians at each of our facilities so that we can come up with strategies for improving our system. And it's also specialty and clinician driven. So the specialists and clinicians themselves can drive the data at their regular specialist meetings, their team meetings, so that they can investigate particular areas. So Charlie is going to just take you very quickly through one of our strategies.
So this is a screenshot of our clinical variation application, and as Teresa touched on, we review some of the high volume cases with the low complexity or relatively low complexity, so we can see whether there's determine any variation there. As you can see, we've got a number of different measures which we can review on. So for this case, we decided to review the laparoscopic cholecystectomies without any complications. And against average length of stay, immediately you are able to identify that there's an outlier there, being Canterbury Hospital, with an average length of stay about 0.7 days, or close to a day over the rest of the district. So what we did, we engaged our clinicians at each of their sites to review the data. They undertook a review of the data, assuming that potentially it was an issue with the clinical outcomes and the clinical practice. But once they reviewed the data using this system, they were able to determine that the clinical outcomes were really unremarkable, and it was really an issue around the business process and scheduling around emergency theatre time. So what we've done now is just organised a bit of a mini redesign of our surgery theatre time at Canterbury Hospital. So we're able to allocate dedicated theatre sessions to the upper GIT and gastroenterology units, so they're able to bring in these patients in a more scheduled and timely manner. So hopefully once we do that, we'll be able to turn the overnight peer bed day variants around in a few short months.
I'm speaking as a clinician. And not because I've got any expertise with the portal, but because the portal team came up to Warrington a little while ago and gave us a demonstration. We got lots of clinicians there. We got the whole of the orthopaedic service there, which is the first time any of us have ever seen them in the one room together. So it demonstrated a couple of things, I think. One is that doctors are really hungry for the information. So when they heard that this was being demonstrated, I think they really thought that this was a great opportunity. Doctors are very competitive. They're not actually adversarial like lawyers, but they're certainly very competitive. And we also know that in a survey in the BMJ some time ago that 90% of doctors assess their own clinical skills as above average. So they're a fairly ambitious group. And I guess once they heard that there was a portal where they could confirm that they were in the top 90%, they thought this was an opportunity. So I think they are hungry for data, and I think they do act on data, as Brian has said in the past. That's excluding hand hygiene data, of course, but they do respond to all the other data that's presented to them. So that's why I think the portal is really good. And I'll just speak from the clinician point of view, although there are various levels at which people can interact with the portal, I think. So clinicians are in that group, but there are specialty groups above them, the specialty group in which they're working. There's the area of the hospital in which they're working, and they could look at all those facets and outcomes. And then there are the patients at the base of the triangle, and I think ultimately, once we can start drilling down from specialties to individual clinicians, which I think everyone would like, then we're well on the road, I think, to public reporting, which I think has lots of challenges, but I think also lots of benefits for the community. So that's basically what the portal, I think, is going to do for us. It's going to look at our costs, look at our efficiency, confirm for individual clinicians that what they're doing is best practice and is up with their peers. And I think, as has been mentioned, it's also going to give us the opportunity to look at clinical variation, which is really important. Where does the information come from? And that's always an important issue because when clinicians see information which isn't adulatory and confirms their 90% above average status, they tend to say the data's wrong. So I think the important thing with this is that the data that is on the portal is the data that we're all actually inserting into the portal. So if the information's wrong, it's then our responsibilities as clinicians to drill down into the information, into the data, and to correct it. But the portal gives us great opportunities, I think, for actually doing that. When we see figures and when we see our results, as we'll see rather painfully in a minute or so, it does give us those opportunities. So there are just two things we're going to look at. One is this particular DRG, and it's at the hospital I work at, Orange Hospital, and it's chronic obstructive airways disease without complications or comorbidities. And this one was picked because it's common. There were 10,000 inpatient services last year throughout New South Wales for this at a cost of $48 million. So it's fairly much bread and butter stuff. We're looking at Orange, so we go to our major hospital peer group, and the hospitals in our peer group are all listed there, and we can, in Orange, look at our performance in terms of costs and length of stay with our peers and with the peer baseline cost. So as you can see from this, we are below the expected ALOS, we're below the average length of stay, but we cost considerably more than the average cost for this admission, for this DRG. So with that, we can then go and see why perhaps there's a bubble graph on the top which just transfers that information into information that we can perhaps more easily visually look at. But we can break down the costs. The costs are broken down for us, so that we can then see why, even though our patients are in hospital for shorter than the average time, the cost for Orange Health Service is significantly greater. And I guess there are two of the figures that stand out. The other figure that stands out, which we don't mention, is other. And other is pretty expensive, like it's 25% of the cost. So that's interesting, and we could, I guess, blame other for being the reason that we blew out the silver service and those kind of things and the wine with meals. But it may be there are other possibilities. We've got a PPP arrangement. We're in a new hospital, 3 years old. It's a PPP. So some of the costs that. But obviously, if we're going to work out why we're more expensive, we need to look at what those costs are. If you look at these two costs, though, critical care and pathology, we can see that they're significantly more expensive. Critical care, the mean $194, our average is $514. And there are a couple of issues in that. Are we inappropriately admitting these patients without complications to critical care services? Or, in fact, is our documentation poor? And, in fact, are these patients not patients with uncomplicated COPD? So are we miscuing them? Are we not? Are they in the wrong DRG? And is our documentation inadequate? So that's something we can go and look at. And pathology is the other cost. So pathology is significantly greater. And there are two possibilities here again, either that we're over-ordering tests or that the cost of our pathology services is significantly higher. And they're things, given that we've got that information, that we can now go and look at. That makes it a bit easy for you to see it, I'm sorry. And that's just rubbing it in for orange and for the people back home. The other thing, just to look at briefly, is the single patient journey. And I think this is really interesting, and it really bears on the discussion we had just in the last section. So this is, I guess, this is hotspotting, as they call it in America. They look at who your the frequent flyers we've heard mentioned, but we look at patients who really are the regular attendees, and we look at them because, firstly, they're costing quite a lot of money, but secondly, what are we doing wrong that these patients are presenting to the hospital so frequently? So there's this single patient, total cost $60,000. Acute and their admissions, non-admitted is a smaller lump sum, but the admissions, the $40,000 worth of admissions, is obviously significant in this cost over a 12-month period. And this would be quite a few. I don't know what Tony in Alstonville charges for a consultation, but it's certainly, you'd imagine, a year of weekly consultations at least for $60,000. So where do these costs come from, and what are the treatments that the patients had? So we can look at this over the last 12 months. We can look at their inpatient services, and they've had 5 admissions in the last 12 months. They've also had, thankfully, some community-based interventions as well, and there was a swag of them there. But I suppose there are various things that come from this. One is that the individual clinician that may have looked after this patient on one of these 5 admissions in the last year may not have been aware that this was just one of 5 admissions. I mean, one would hope the clinician was, but maybe he wasn't. Each of those individual admissions may have been without complication, they may have been fine, there might have been no IMS or no adverse events, and so everyone would be happy that that was a satisfactory course of treatment for the patient. But it's interesting that at the IHI this year, Renan Alberti and Charles Vincent were talking about where quality and safety is going now, and they said in 10 years' time we'll probably be less interested really in IMS and RCAs, and probably what we should be concentrating on is the patient journey. While we don't have problems with any of these 5 admissions, the patient obviously may well. If we ask the patient what the patient thought her health had been and her healthcare had been over the last 12 months, she probably would have given a very different, he or she would have given a very different answer to what perhaps we as individual clinicians might think. So I think it's this really points to the importance of integrated care, and it points to us looking at the whole patient journey rather than just individual episodes of care. And I'll hand over to Rohan.
So some of you will be sitting out there and going, so what? This is just another lot of data coming out of New South Wales Health. It's not going to change anything. Back in the last century, when I started my journey into healthcare management, an unplanned journey, I used to go around to our case mix unit and get wads of tables of paper showing length of stay for the different clinicians, and then I'd go and talk with my physician colleagues about why one patient who had heart failure had a length of stay of 2.6 days, and Another patient with a different clinician had a length of stay of 13 days. And of course, the old answers used to be, well, the data's wrong, or my patients are special, or, the standard things that we've heard for a long time. And we'd work through that with the clinicians, and that would lead to opportunities to improve practice to improve outcomes for the patients that we're all working for. It used to be laborious, as Teresa and Charlie have mentioned. It was a difficult process. This portal, and you haven't seen the power of it, we can run a live demonstration where we run 50 million lines of code live and give data on available in real time on every single individual patient in the state hospital system to allow clinicians around the state to really understand what's going on in practice. Now, it operates at a whole lot of levels. We actually invested in this technology so that we at a whole of state level could understand the costs of the system and how different parts of the system were performing. And it's very easy for us to compare performance in LHDs, in hospitals, in individual clinical units around the state. And then at an LHD level, it becomes an important management tool in understanding how the services are running, how they're performing, and it can be easily contextualised to deal with the critical clinical day-to-day operational management issues that the LHDs are dealing with, and that's very much what STARS is all about. But at an individual clinician level, which is what we are hoping to make available over the next few months, we're in the final stages of procuring licences for access for every clinician in the state to this sort of real-time data that will help guide your own practice and how you're delivering healthcare. The answer to some of Brad's questions, how are we going to bring those fringe dwellers of the health system that don't necessarily get access to services, is to start to ask the right questions about how we're spending our money and how we're delivering our care. Back in 2001, we did a piece of work here in New South Wales, the Rational Investigation Ordering Collaborative, and we demonstrated that between 25 and 30% of all the pathology and radiology tests that were ordered in a number of hospitals that participated in the collaborative were completely non-contributory to patient care. Millions and millions of dollars of potential resources available to be spent in other ways, and in a devolved environment where LHD boards can make conscious choices, having views on this sort of information about where they're going to invest their allocated budget to deliver the right outcomes for their population. This information becomes incredibly powerful to improve the whole system and to bring along those parts of the system that haven't had access to those resources. The Grattan Institute, when it started to look at an analysis of how activity-based funding is taking effect around the nation, said there are certain things that governments should be doing. State governments need to set the right price for the services that they're purchasing. In New South Wales, we clearly have a state price. It's below the national efficient price, reflecting the very good state of the New South Wales health system. We have to provide the right information that enables the right sorts of signals about the type of care that should be provided. So the activity-based management portal and its local contextualisation through systems such as STARS provide the tools that we're going to need to give the system the transparency and to deliver the accountability about how we're utilising our resources across the system. As Gabriel mentioned, it allows us to really start to grapple with the entire patient journey, to make rational decisions about whether it's better to have people just turning up to emergency departments up to 100 times a year, as we see in some LHDs currently, or whether it's better to invest in case management for those individuals as a cheaper and more effective option to deliver the right health outcomes for them. Those are the rational decisions that will be facilitated by this sort of information. So what have we learnt over the last 18 months of developing this portal and seeing how groups like Sydney Central have progressed this? Clearly, this has to be something that isn't just data coming from management for management purposes. This needs to be information owned by clinicians, involved at every stage of the process to design the right sorts of care that they want to deliver for their patients, to deliver those outcomes. Teresa's right, we do need the right sorts of investment at local health district level, and we're trying to get that message out at every opportunity. We want you to play with this information, we want you to use it, we want you to analyse it, and we want you to deliver better outcomes as a result of it. We will continue in New South Wales as far as we can from Miller Street to provide an environment in which there is transparent information available to you out in the system to help you deliver the right outcomes for the people of New South Wales. And we'd be delighted if you'd continue to work with us on things like the ABM portal. Thanks very much.